And what's caused the stenosis and the stenotic ear canal in this patient is they previously suffered from multiple perforated eardrums due to noise exposure. They were in the army, so they're exposed to firearms and heavy ammunition. In addition, they suffered from chronic ear infections, and it's very likely it's the chronic ear infections that then led to the stenosis. And you'll know, if you just keep watching, you don't want to miss this, you'll just see how narrow both their ear canals are. So when you've got a stenotic ear canal, there is possible surgery that can be done to a meatovoplasty or canaloplasty to widen the ear canal. However, ironically, although this patient's got a stenotic ear canal, when it's not blocked like it is at the moment with dead skin, they can hear really, really well. Now, this is not earwax, it's dead skin, and what's happening is, again, you'll see in a moment, because the ear canal is so narrow near the eardrum, the skin that's migrating, so it's dying and shedding off the eardrum and the medial ear canal wall, as it's trying to migrate sideways out of the ear, it's just getting trapped because the ear is so narrow. And so they need regular cleaning. They've also got a bit of evidence of medial canal fibrosis. So some people who suffer from perforated eardrums, when the perforation heals, they get a buildup of fibrous tissue. It's also known as false fundus. It's almost like a fake eardrum, a second eardrum. And I have a feeling they've got a bit of that as well as stenosis. And as you can see, I'm just using a fine end suction gauge here, and I've gently peeled away the keratin, the dead skin, off the canal wall. And now I have to remove it from this really small section of the ear canal that's narrowed. And I'm now going to resort to the forceps. I'm using the microjaw, I'm going to be using forceps in a moment. And I'll be using the 3mm microjaw forceps, which are really slimline. Obviously, if I use large forceps in here, it's going to be very difficult to gain access. I'm almost just prepping it a bit. I'm just trying to just peel away the skin off all the way around the perimeter as much as I can. And here we are. So I managed to get the forceps in. And it was a bit of a tug of war. We have to be really gentle. As you can imagine, this skin is really attached and adhered. And this ear canal doesn't want to let go of it because it's so narrow. It's trapped beyond this narrowing as well. And you might have had a glimpse there, but that's the patient's ear canal. You can just see how small it is. And through there is the patient's eardrum. So the eardrum's slightly inflamed because this keratin was attached to the eardrum. We removed it, but it was instant relief. They could hear so much better. So there is surgery possible so they can open that up, but patient's very reluctant to undergo that. Similar with, this is the patient's left ear. I would say it's slightly wider. It's not as stenotic. But again, same ritual, just trying to peel this skin off the canal wall, just to try to detach it. And then I'm going to go back in with the forceps. We're going to get a good grip on this and gently pull away. There we are. So I've got the jaws around it, the teeth of the jaws, I've got the grip. So I pull the first section away. So this keratin is gone, and similarly with the patient's first ear, the keratin was actually beyond this narrowing. So we have been pulling it out. There we are. So this skin that I removed was originally on the patient's eardrum. It died and it shedded. It should naturally migrate, but it got trapped in this small orifice. I'm just going back in. It's a bit of clarinetting here. We have to be a bit careful. So fine end suction gauge is always good with clarinetting, but there's a point where I had to stop because I thought, it's getting a bit too loud. And I think that's coming up shortly. But again, the patient can hear much better now. You can see a bit more of the eardrum here. You can see the bluey tinge around the perimeter. It's still a bit inflamed.